Now I'd like to introduce Betsy Thompson. She is the director of the Division for Heart Disease and Stroke Prevention at the Centers for Disease Control and Prevention, and a captain in the U.S. Public Health Service. And in that role, she provides public health leadership to improve cardiovascular health for all and reduce the burden and eliminate disparities associated with heart attack and stroke. And Betsy is a member of our board, which we're very grateful for you to help with that. And if you could introduce your distinguished panel. Thank you.
I will introduce them, although I know they're going to tell you more about themselves and their work as we go through this session. So to my right is Dr. Steve and Sidney. Steve is the Director of Research Clinics for Kaiser Permanente, Northern California. Also, they will correct me if I get any of this wrong. Next to him is David Goff. Many of you know David is the Director of the Division of Cardiovascular Sciences at the National Heart, Lung, and Blood Institute at NIH. Dr. Janet Wright is our Executive Director for Mammalian Heart. She sits partly in CDC and partly at the Centers for Medicare and Medicaid Services. And last but not least is retired General Doug Robb, retired from the U.S. Air Force and now on faculty at both the Uniformed Services, University of Health Sciences, and the Defense Health University, I believe. National Defense. See, I told you they'd correct me. So this morning, what we want to do is really engage more in conversation. We don't have 5 PowerPoints. I think you'll be relieved to know that we're going to sit and show you. There are a few slides, but we really wanted to have a conversation amongst ourselves, but also involving you. So we will be making sure that there's time for your questions and some answers to those as well. To kick it off, you all have in your packet this monograph, Losing Ground, also fondly known as the Sidney Report by many. And to kick it off, I really wanted to start with Steve to talk to us about what is it that we need to know about this report. It's titled Losing Ground, Heart Disease and Stroke Deaths Hit Hardest Right in the Middle. So Steve, what do we need to know? It's not real long, but boil it down even further for us.
Well, just basically summarizing the main points from this, we recently published a paper comparing mortality trends from cardiovascular disease from 2000 to 2015 in the United States as a whole and in Kaiser Permanente, Northern California, which is a large integrated healthcare system that I work for, covering about 2 million people providing health care. And not surprisingly, mortality from cardiovascular disease is a lot lower in Kaiser Permanente for many reasons. I don't think that would surprise anybody. But what stood out and actually was surprising to us that the trends for those ages 65 and older were similar in terms of percent change in mortality over 15 years. There was a much different picture under the age of 65, so that the rate of decline, and there has been a long-term decline with some recent slowing nationally and in Kaiser Permanente, but the rate of decline was twice as fast in Kaiser Permanente than in the United States in those under the age of 65. Now, we focused in this report on 45 to 64 years old because there's a lot of people who die from heart disease. Actually, 1 out of 6 deaths from heart disease occurs in that age group. And it's about 120,000 deaths a year in those age 45 to 64. So we had the finding, and the question is, why did this happen and what to do about it? And I think that's what the discussion is about today. Now, what we think happened is a confluence of 3 things. One, overall in the country, we've been trying to strive for ideal cardiovascular health, 7 measures developed by the American Heart Association, and we're not doing very well on that. About 40%, I think up to through adolescence, But once you get, way past adolescence, it drops off. So by the time you're up to about age 50, you only have about 3%, definitely quite a bit less than 10% of the population. So those are your kind of your primordial risk factors, so that if you do all the things right, then most people will avoid getting things like hypertension and high cholesterol. So we've kind of not done very well with that. And the result is that we're getting people with risk factors, and a lot of them at a fairly young age. And we don't do very well treating them. And there's an example in the report for hypertension, where in young adults under the age of 40 is about a 40% control rate. And that contrasts with Kaiser, where we have much better control rates, over 70% in that age group and about close to 90% overall. So the final factor then is, I think, the diabetes, obesity epidemic that started in the mid-'80s and has had enough time to settle in and cause real damage, itself being a risk factor, and also being associated obesity with other risk factors like hypertension, hyperlipidemia. And I think we are seeing this particularly in this age group because of these other factors. So they don't get treated as much as people in an older age group. And I think it's probably somewhat a lack of consciousness about, treating in younger ages. That's my own theory anyhow. And I think in order to address this, and I'm sure we're going to have a lot of discussion about this, we have to, address cardiovascular health, ideal cardiovascular health, and risk factors. But given that we're in a situation where we've got a middle-aged population now that's had things like hypertension for decades at this point and other risk factors, we also need to treat them aggressively at this point if they do have the risk factors and if they do have any manifestations of cardiovascular disease. Kaiser Permanente, it's not the only system, and I'll say one last word about that, is that we have spent a lot of resources, not me personally, but the organization, in educating providers and also providing relatively simplistic algorithmic systems for treating hypertension and addressing people who have evidence of atherosclerotic disease. So I'll leave it at that for the moment.
Thanks a lot, Steve. There's so much there to unpack and a lot of food for thought. It makes me think about a fairly recent study done by some of our scientists. Adam Bond led it, where we looked at county mortality rates from 2010 to 2015 and showed that the majority of counties, actually, it's not just that it's stalling, it's actually an increase in heart disease mortality in the majority of studies for most age groups. So lots of things to think about. I wanted to go to David and see, NIH has done a lot of work in this area and given it some deep thought. David, can you talk to us a bit about your strategic priorities there and how that might help us, as the title of our session is Get Back on Track?
Yeah, so thanks, Betsy. First, I want to thank the group for organizing this session and including me in it. I also want to thank everybody here for the work you do. It's really important, and we feel very privileged to be a partner with you in that effort. So, we've been observing the same trends that Dr. Sidney and Dr. Thompson talked about, and this comes after 50 years of progress in declines in heart disease and stroke. And so we're seeing stagnation, maybe reversal this decade, and it's quite concerning. In addition to that, we see enduring disparities in the burden of cardiovascular disease. A recent paper showing that the burden is greatest in what you might call the heartland. Other people call it the coronary valley. The Ohio and Mississippi River valleys, so Appalachia, the middle of the southeast, stretching over into Oklahoma as well. These are the parts of the country where the burden of heart disease is even the greatest. And so with that backdrop, the status quo really is no longer acceptable, right? I mean, there's that old trite saying, if you keep doing what you've been doing, you'll keep getting what you've been getting. And so we have to be doing something different. And with that as a context, it's important to recognize that when our director, Gary Gibbons, he started at NHLBI about 6 years ago now, and one of the first things he did is, good new leaders do, is he charged the Institute to come up with a strategic vision. That was published about 3 years ago. It was a result of a process that engaged thousands of scientists around the country and indeed around the world in a crowdsourcing effort, led to a document that has 4 big goals and 8 objectives and 130 some compelling questions and critical challenges. And what it really represents is not us, the Institute, telling you what we think is important. It's really you and your colleagues telling each other what you think is important to advance science in heart and lung, blood, and sleep. Now, my division focuses on the heart part of that, and our mission is turning discovery into cardiovascular health. That's the NIH mission, turning discovery into health, with the nice word cardiovascular inserted. Makes it really kind of simple. And when I got there about 2 years ago, Gary asked me to develop an implementation plan for the division, because if you have a vision without a plan, it's just a dream, right? So we had to come up with a plan for that. And so we re-engaged with the community, and we've come up with a plan that has resulted in identifying 6 areas that we're going to focus on going forward. They came about from looking at the situation through several different lenses. We thought about a social determinants of health perspective in terms of what are the root causes of the problems that we're having. We also asked people to look at this from a life course perspective, from the womb to the tomb. What can we do to improve cardiovascular health? We also asked people to look at a translational spectrum perspective. We're responsible for supporting basic science research, and that is actually the majority of what we support. But we're also responsible for supporting population science and implementation science. And so we need to get better at understanding what the information needs are of policymakers. What information do policymakers and decision makers like you, what do you need so that you'll know what to do to make a difference in cardiovascular health at the population level? We're a research agency, not a public health agency like CDC, so we support research. But it'd be useful for us to be supporting research that generates policy relevant information to help all of you do your jobs better. So the 6 areas that we've identified, the first one is addressing social determinants of cardiovascular health and health equity. And that first word is really important. It's addressing. It's not understanding. It's not describing. We've done a lot of that over the past couple of decades, and it's really time to move on beyond understanding and describing to really addressing. So we're really interested in supporting research that tests innovative strategies to actually do something about social determinants of cardiovascular health and health inequity. Beyond that, the other 5 are to support research on enhancing resilience, on promoting cardiovascular health across the lifespan, on eliminating hypertension-related cardiovascular disease, on reducing the burden of heart failure, and on preventing vascular dementia. Now, these areas of focus are influencing the scientific workshops that we are holding, where we invite scientists in to come and give us their best advice on the sorts of things where we need to lean in as an institute, as opposed to just allowing the investigator-initiated peer-reviewed discovery science to bubble up and generate discoveries. Sometimes the Institute needs to lean in with an initiative, and we look for advice from the community on where we can make a difference. And there are some recent examples where we're doing that in some of these areas. You may be familiar with the SPRINT trial, which showed that more intensive blood pressure lowering could reduce the risk of cardiovascular death. Well, recently there was a report from that trial showing that it's also good for your brain health. So there was a reduction in development of cognitive impairment and dementia, and a reduction in the progression of white matter lesions at brain MRI. White matter lesions are bad to have. They predict onset of dementia. So blood pressure lowering is good for your heart and good for your brain. Reduces the risk of stroke as well. We also have done some work to try to figure out how to get blood pressure control better implemented, because it's one thing to say it's a good thing to do, but then how do you do it? And we've been supporting work like Ron Victor's work in barbershops in California, where he showed that putting pharmacists in barbershops where they have the ability to do prescription, testing blood pressure and prescribing in the barbershop resulted in improved control of blood pressure, especially in African American males in those communities. That's a big step forward to proving an effective implementation strategy that we now need to figure out how to roll out across the country. So that was just one city, and we need to figure out how to do it more widely. There's other things we could talk about. I think, we're interested in children, but I think at this point I'll stop there and let us keep going.
Well, thanks, David. I think that's a good lead in to what I wanted to ask Janet, and you also answered another question I had for you, which was to give us some examples of your most recent policy relevant research, and you just did that. So Janet, back on track here. The idea of implementation and what works. You've established this rich network of partners and hypertension champions through Million Hearts. Give us some rays of hope. What are you seeing out there that gives us hope that it's not just, no offense to Kaiser, Northern California, it's where my husband works, but what about those of us who don't have the rich infrastructure and the systems of Kaiser?
Thank you, Betsy. And I want to thank the National Forum, John, I don't know where you are, and Jennifer for your leadership. And all of you, I see so many familiar faces in the room, and I hope the rest of you, I get to know you before the end of the day. Greetings from Million Hearts. As Betsy said, we are partially at CDC and partially at CMS, but really connecting a lot of partners around the country, many of whom are in this room. So I think there is hope, even though these statistics are daunting, and colleagues at CDC published recently an analysis looking at the events that occurred in 2016, how many, there were way too many, particularly when you think about this as a preventable disease, heart attack and stroke. But we looked also at the 35 to 64-year-olds and found that in that age group, they were less likely to take aspirin when they had an indication for it, less likely to take a statin, though they fell into a group where it was recommended, also were more likely to smoke. And in that age group, the blood pressure control in the data that we looked at, these were NHANES data, was hovering around 50%. And I think one of the statistics, those are staggering enough, but then when you look at that age group and physical activity, a solid third were getting less than 10 minutes a week. So it does confirm and sort of align with the data that Steve has presented. So considering those are our workforce, our parents and our caregivers and employers as well, we clearly have to focus attention here. Continue the gains in older Americans, but begin to focus more upstream. The Champions program that CDC has run for the last 7 years has given us a chance to see areas of high performers. So over that period of time, we've recognized 83 places in the country, ranging from solo practitioners and community health centers, all the way up to places like the VA. And the thing that these champions have in common is that they have all achieved blood pressure control rates, started out above 70%, but now it's averaging above 80% for their entire population of hypertensive people. And when you look at what they've done with extremely diverse populations, some that are challenged for the basic needs of life, some homeless, they've adopted systematic approaches and then adapted them for their populations. So it really resonates that they are coming up with local solutions, but they're doing it in a systematic way. The lessons that we've learned, sort of principles that we've extracted from these very generous high performers, is one, they all prioritized hypertension. They sat down, whether it's big group or small group, they pulled whoever they needed to together and made the case to prioritize across their entire practice. Just the fact that they had that conversation is extraordinary. When you set priorities, everything else changes. When you set an aim like preventing 1 million heart attacks and strokes, it tends to focus the mind, particularly if you assign a time frame to it. And by the way, there are 38 months and 7 days left in 1 million hearts. So I'm focused. So they prioritized. Through the process of that prioritization, they found a champion and they recruited a team, people who really cared about this. But they distributed the priority throughout their entire clinic or practice or set of clinics so that everybody knew, from the person who checks in the patient to all of the clinical staff to the back office people, everybody knows in that practice that hypertension is the thing. And when you talk to patients who are in these practices, the reactions range. I mean, they give funny anecdotes about it. I remember one person in Wisconsin telling me they wouldn't leave me alone. They kept pestering me about their blood pressure. They call me at home, they send me emails, but it was done in a way that told you that that person felt cared for. And that person started to experience ownership of his blood pressure, which was another astounding factor. So prioritization, champions, and a good team, and then they were immersed in their data. Some very sophisticated systems, some were back of the envelope, spreadsheets that they printed up and everybody gathered around. But the point was they knew how they were doing, and they revisited that performance on a regular basis, usually weekly, and then continued to problem solve about why and where they were stuck. We saw in some places the incorporation of out-of-office blood pressure measurement, home monitoring, or SMBP. We know now that the pressures that we get in an office may not reflect that person's blood pressure, and so we need to start gathering data from other aspects of their life, and more important, a pattern of blood pressures. So many of the places, including federally qualified health centers, are beginning to incorporate out-of-office monitoring. It's a struggle. There are lots of things that need to be worked out, but it's definitely being pursued, and people are being enthusiastic about the results they're seeing. The other thing they're doing is making sure they don't miss anybody. So it's one thing to control the blood pressure of the people that you know have hypertension, but are you catching everyone? Are there people hiding in plain sight? And there are best practices on how to make sure you're using your tools to catch all those people and then make sure they get on the road for treatment or get blessed and told that they don't have hypertension. And then what most of these places do is celebrate along the way. So they don't wait until they reach a certain aim. They're actually celebrating all the small milestones on the way to keep the team nourished. So all that stuff I just said about hypertension, very exciting. We feel like it can be done. We know places where it's happening in addition to Kaiser. But the really exciting thing is that all of that stuff I just said can be applied to LDLs over 160, right, Kat? People who are likely to have FH or a very high LDL for other reasons, can be applied to diabetics who are not being identified or managed. So it's the process that is being honed by these places that gives me hope that with more scale and spread and more adoption of these systematic approaches, we can get these risk factors under control. And what Steve points out in his report, I think the CDC folks did as well, raising the radar for clinical people to make sure that younger folks are being attended to, being identified, and being managed, and also conveying to those young people they may not be as immortal as they think they are, and that it might be in their best interest to take medications in addition to modifying lifestyle, as hard as that is. But really having those conversations and raising their awareness of their risk.
Great. Thanks. So are you feeling a little more hopeful now out there, I hope? Because it really is, you've described a basic quality improvement process, and that can be done in any setting. It may be using a different system, but that's what you've described, being able to find in a variety of settings. Speaking about a variety of settings, Doug has done some pretty remarkable work, I think, with notable success in the tobacco cessation arena, in particular among active duty military. Doug, could you tell us a little bit about that and what you've learned that might, again, be applicable outside of the active duty for the folks in this room?
Well, thank you for the opportunity. Real quick, is Don Shellen here? Is he here? Office Secretary, Assistant Secretary of Defense for Health Affairs. Okay, good. No, I'm just kidding. No, we always have to, in the department, we always have to have the disclaimer. Okay, these are the views of my own. okay, and not the departments or the military services. But some people say, "Why are you here then?" So it's in my former life as a military medical officer, I had the honor and the privilege when I was the director of the Defense Health Agency, and then previously before that, the senior medical advisor to the chairman of the Joint Chiefs of Staff, to serve as the co-chair for what we then called back then the Defense Advisory Committee on Tobacco. And so I want to use that as the framework of there was the task force that was created to look at the issue of smoking cessation efforts in the Department of Defense. And then I'm going to kind of back up on the history or the journey to get there. I actually kind of titled this non-scripted talk, from the art of the possible to the art of the doable, because they're different, okay, through the art of the compromise. Mayor, we know all about compromise, except on the football field. Go Packers. Go Packers. So we're going to talk kind of like, and I'm going to start in 2011, which is when we had a series of studies out there, and one of them was the health-related behavior survey, that one of our surveys that we do. We had about 24%, almost 25% of our active duty service members were self-reported as smokers. And you go, that would be higher than your communities. Indeed it is. And back then, it was hovering, self-reported back then, of course, civilian was around 19% back in 2011. Now, fast forward a couple years, as you know, everything that's in the Department of Defense is what I would call, many of the things we do is on the suggestions of the Congress, the House, and the Senate, and the President. And so there was a very forward leaning member of the Senate on the Appropriations Committee had directed, not suggested, there's a difference, okay, that directed that the Secretary of Defense do more to address tobacco use in the military to advance, and as he was saying, that the health, productivity, and the readiness, okay, of the men and women that we asked to serve in our military forces, Army, Navy, Air Force, Marine Corps, and Coast Guard. Now, one would ask, why would, in the big picture, why would we care? Other than the altruistic reason of, well, because we want everybody to be healthy. So, but sometimes when you're in big business, the Department of Defense is big business, okay, you've got to remember where the drivers are. So, depending on how it doesn't really matter what the exact number is, but let's say it's over $1 billion, okay, was spent on readiness, health-related issues, okay? So, you say, well, that's a lot of money. So every dollar that we spend, so think about what's going to get, you got to understand what's going to get somebody's attention. Is it, well, I want my people to be healthy, or, hey, every dollar I spend on acute effects of smoking, chronic effects of smoking, lost duty days, inability to train, let me add those all up, okay? But every dollar I spend on health care or health-related issues, whether it's tobacco or whether it's heart disease or any of the chronic diseases, is a dollar that I'm not spending on sailing ships, steaming ships, flying sorties, or going to the firing range. Or that's a dollar that I'm not spent on modernization of the next generation of our military forces that our nation asks to protect our nation's borders. So you got to start thinking in the big picture, how is all that related, and how do you get people's attention? Is it health, or is it the dollars spent on health, okay, that can be used for other areas of improving the readiness posture or the readiness capability of our military? And I think that's important to understand. No matter what domains you're in, you got to understand the big picture. Now, about that same time, again, and if you look at, there's going to be a confluence of what I call tectonic shifts that came together that helped move where we did in these last couple of years. And at the same time, then Rear Admiral Lushniak, who was acting U.S. Surgeon General, he gathered a coalition, okay, it's a nice word, okay, of folks like the American Heart Association, American Cancer Society, and other various groups, okay? And they basically went door to door to our Congress and our senators, okay? And used to highlight the fact that they were celebrating what? Back then, the 50th anniversary of the 1964 Surgeon General's report on smoking and health. And he said, hey, we need to kind of re-energize that, okay? And there's a whole nother backstory on how many people didn't want him to do that, as you can imagine, because we have all been fighting a battle. We know that the enemy's out there, and sometimes we know where the enemy is, and sometimes we don't know where the enemy is. But you can imagine, but that movement helped, believe it or not, that parallel effort, and that's why I talk about interagency. So that's why I would love to see, we've got city coalitions here, we've got municipal coalitions here, we've got state coalitions here. It's important that you've got that interagency, interdepartmental folks working together. Whether it's planned or unplanned, it doesn't matter, but take advantage of it. So prior to 2014, okay, when we were directed, the medical side of the House, the Office of Assistant Secretary of Defense for Health Affairs and the Surgeon Generals, we had always tried to get consensus for a comprehensive tobacco policy, okay, that was basically focused on poor health outcomes, okay, because that kind of made sense to the medics, right? And recently, to kind of what we call impacts on human performance, because we thought maybe that would resonate with our line counterparts. At the end of the day, we serve and work for the line. The leaders of the Army, Navy, and the Air Force and Marine Corps. Okay, but as pertinent and as logical as those approaches were, okay, we've all Mayor, we've all faced those issues. When you're looking at all your retailers now, what do you mean you can't smoke in my place? So this failed to build a sufficient, what I call coalition of the willing, for creating a comprehensive DoD wide. So we figured that we had to change our direction, our focus. So, but then the Secretary of Defense, and this is June of 2014 when I came in on board on this, and that's when he stood up the Defense Advisory Committee on Tobacco and was chartered to create a unity of effort. Unity of effort. Okay, and that's an interesting concept in the military. And we're used to what? Unity of command. Okay, there's a difference. But you all live in a unity of effort world, and then this was kind of new to us, by the way. Unity of effort, but it worked, by the way. So, and the focus in the letter was increase tobacco cessation, prevent the initiation of tobacco use. So you got to set, what's your mission? We're in the military. What's my mission? Okay, all right. So, and it was a three-pronged approach. Okay, increase tobacco cessation, get those folks that are smoking to quit. Prevent the initiation. That's probably a good deal. And then reduce secondhand smoke. So that was the 3 lines of effort that we kind of decided and settled on. Now here's what's key. The membership was 25 members. And you all say, wait a minute, you got 25 members? All the stuff that you've read, that's too many? You're right. Okay, except this crossed so many domains that we felt it was necessary. And it was folks from the military service, the Office of Secretary of Defense, people that had skin in the game, okay, and to include those who could say no. And I think that is so important that when you are moving forward on your efforts, you've got to include those people with you who could say no. Okay? Because it's better for them to say no and then shape them then than it is for them to drop the no card at the end when you have your recommendations. So what we did was to build that support and to achieve that consensus on whatever our recommendations were going to be on a DoD-wide policy. Okay? We addressed what was relevant and important to senior military and department leadership. Okay, that was a different, significant shift. It wasn't health focused per se, but it was sometimes putting the health focus in context of what it meant to our military leadership. And that turned out to be key. Because think about it. I still remember sitting in one of those meetings. I'm talking, and I remember one of the 4-stars saying, Doc, come on. You're asking our soldiers, sailors, airmen, the guys we put life on the lines, you tell me they can't drink, they can't smoke, they can't eat what they want to eat, and yet we ask them to put their lives on the line. So remember, that's the context that we were living in. And you know what? He was right. He was right. So we had to shape our messaging and our way ahead. And he was right. And I still remember answering one of the senior enlisted guys, Doc, I can't ask my guys to quit smoking. And so I said, I got to get on this guy's good side. I said, I'm not asking you to ask him to quit. And he looked at me like, Doc, you're not? I said, no. I said, I'm going to ask him to smoke less. He goes, I said, there's a difference here. So in other words, I'm going after what he's thinking. Okay? I'm not asking him to quit. Okay, I would like him to quit. But how about let's just start with, I'd like him to smoke less, because we know it's dose dependent, right? So, and I kind of explained to him it's dose dependent. If he smokes 10 cigarettes a day instead of 20 or 30, okay, he's going to be healthier while he's on active duty, and he's going to be healthier downrange, and you're going to have more dollars to go to the shooting range, fly sorties, and steam ships. So I was kind of putting it back in context, okay? But then again, we have to have the effort to keep the next generation from starting to smoke. So it was kind of a, a phased approach. But when I said that to him, I kind of saw him lean back, and he said, okay, I'm listening now, I'm listening. So what was really resonating with our Department of Defense military leaders was that we needed to have an optimized approach, okay, that balanced the health, the welfare, and the readiness of the force while respecting the rights, the individual liberties, okay, and the responsibilities of each service member and their families, okay? And I'm sure that's what you all struggle with at the municipal, at the city, and at the state levels, is how do you balance, that? And so we kind of put everything in that perspective. So the committee's membership, again, this community agreed to the end state. And we all agreed to the end state was prevention of the initiation of smoking. Okay, they could all live with that. Okay, prevention of involuntary exposure. So that was big, because now that was saying, hey, look, this is, and I'm going to tell you a little story where this was huge, and starting to sway some of the installation support commanders on, hey, this is too hard to do, Doc. I said, well, do you know what your people are telling me? Not telling me, but telling you that you weren't reading. Okay, and then also looking at again respecting the rights. So we took all the NIH recommendations, the Center for Disease recommendations, took them all together, brought them all together, and then we put them together for our policy. So, but one of the key things, and this is non-scientific, I know it's going to hurt you guys in the room, okay, especially this panel, non-scientific, okay, but every once in a while, the community matters, and we have these things called the interactive customer evaluation, called the ICE, where everybody on base can put in, hey, this is working good on my base, or my installation, this is not working good. But in the commander's mayor are looking at them, okay, and they're saying, hey, but they're not always pulsing them. They're there. But what we did was, we had a very sharp U.S. Public Health Officer captain who got a hold of it. She said, put in 3 words. She put in tobacco, secondhand smoke, and spit tobacco, and she came up with over 2,000 entries in just 6 months of complaints from usually moms, okay, and family members about, hey, secondhand smoke, stuff on the playground, stuff outside my military housing, the smoke coming in the vents. And so we use that to say, installation support commanders, forget about whether you agree or disagree, you're not doing your job. Your people aren't happy. So that was key, the non-scientific body of evidence right there. And so then we also did, again, that we used evidence-based research, and that's the whole thing's focused on the idea of, hey, if we drop the price of cigarettes, we were selling cigarettes 5% below, okay, we were basically subsidizing cigarettes sales in our commissaries, which is our grocery stores, and our BXs, which is our drug stores and our department stores. And so we said, and we had just come out a couple of studies that said, hey, you raise the prices up, up to a certain level, it's with this current generation, that affects your pocketbook, you're going to see a decrease. Now that was the evidence-based part, okay? And so we kind of told folks that. So I was looking to the future. So we brought all that stuff together, came up with recommendations. We can talk about the specifics later. But in April of 16, so 2 years later, Secretary of Defense, it took 2 years. Said in inbox, there's politics here. Trust me. Turn Secretary of Defenses, turn this, turn that. But finally we were able, the folks out there said, this is the time, get them to sign it, because they watched what was going on out there in the political domains and the timing. It had to do with timing. And he signed it. And that was our first comprehensive Department of Defense policy. And so kind of when we look at the results, fast forward, what we've seen, this is just part of it. This isn't all of it, but this effort's coming to date. We saw not just this, but this added to it. We've seen our smoking active duty service member rates drop from back in 2011, which was up to 19-20%, getting down to 14% now. If you kind of look at the right, that's the survey I'm using there. And that's not an insignificant drop. You know, it's about the rates are a little bit higher than the civilian sector, okay? But when you look at all the different efforts that we've had across the boards, you know, we were driving them down. So we were pretty excited about that. But it required a cultural, organizational, systems changes, supported by evidence-based data, as we all know, and most importantly, driven by a unity of effort, okay? But what's next? And this is the part that I always say, okay, what's next? All right, now, we're not going to show you those graphs, but our active duty service member, a smokeless tobacco rate is probably 4 times higher than the reported rate in the civilian sector. And same thing with our e-cigarettes. It's also about 3 or 4 times the rate of the civilian sector. So it's 13% and 12% respectively. So we're currently addressing that next DOD-wide campaign. But we are a microcosm of the macrocosm of the United States. So the Tobacco 21 laws, I think that's important for all our civil leaders in here, okay? Guess what? In Hawaii, the way they wrote the law, okay, all right, we have to abide by that law, okay, because the way they wrote it, who they put the burden of proof on who's selling it. And so we know New Jersey, Oregon, D.C., Mass, Maine, plus many municipalities like New York City, Boston, they're all in the process of writing similar laws. So the DOD will follow suit, okay? And I think what's going to happen, much like we saw with the drinking age going up and smoking age going up, we're going to see a tipping point somewhere. And so this is all a multi-pronged campaign. I'm a military kind of guy. You've got lots of lines of effort, but I think that's going to be key. That we're going to hit a tipping point. And like I said, 51% rules. When you get a certain number of states and municipalities get to a certain level, then the federal government, I think, is going to take notice, and then they're going to probably, drop the, raising the smoking age to 21. So just kind of our journey, kind of an example, and again, looking forward to a discussion on maybe some of the behind-the-scenes work on how we got many of those efforts done. Thank you.
Thanks, Doug, and thanks for doing a little crystal ball gazing there for us as well. You all need to start thinking about the questions you'd like to ask the panel. As I listened to them, there were a few, if not themes, ways in which I think a lot of these efforts, things that they do have in common, and I'm sure a number of you have noticed that too, especially those of you who have been trying to sell the idea of cardiovascular health, whether you're responsible for a city, an organization, a county, a state. We all struggle with some of the things that were mentioned here. I think one of them, it's really around how do you sell it? What is the message that's going to be received? Most of us in this room respond to just the numbers alone, the logic and the numbers, the number of people that are affected, the number that it is cardiovascular disease remains by far the #1 killer. That's enough to motivate most of us in this room. But as you've heard from the panel, it's not necessarily enough to motivate whether we're talking about Kaiser or the DOD, your own city or local area. From the DOD perspective, it sounds like a lot of the messaging was more around fitness for duty, force readiness. When I talk to employers, it's about what's the return on investment for us. I mean, you have to really think about who the audience is that you're trying to get that change in and tailor the message. The other thing I heard in some way, shape, or form was leadership. Whether it's David Goff and the leadership at NIH when there was a change at the Institute. Kaiser, I'm sure you had leaders that had to be bought into the concepts of change. And I know that's been critical of both DOD and with Million Hearts. I'd love to hear the panel talk a little bit more about whether you really agree with that, what I'm suggesting, that having a leader, whether it's the form of a champion in a clinical site, true leadership at Kaiser Permanente, how critical is that to make sure you have the right leaders and the right people, as Doug mentioned, in the room and around the table who have they may be the hardest sell in some ways, but they're also the ones that can pull the plug on something if you don't have them in the room. So do any of you want to talk about leadership a little bit and how important that was in your own experience?
Excuse me, I can address it briefly for Kaiser Permanente. The hypertension, in particular, hypertension control thing came up around 2000, 2001, when it was recognized that Kaiser Permanente had in Northern California had the lowest control rates of any of the groups around the state. It was about 40% at that point. And then it was from the highest levels that leadership decided we've got to turn this around. Some experts were put onto the task, and it included not just that kind of leadership, but each of the medical centers, there's currently, I think, about 21, there's maybe a few less at that point, has a hypertension champion whose job was to kind of talk to the primary care providers about what was going on and how we were doing it. So that those are both really critical, both high-level leadership and local facility leadership, and basically got it up to over 80% in about 8 years, the control. And so that kind of leadership still persists. They're still our local champions.
So I'll add a perspective on leadership from NHLBI and from before NHLBI. So at NHLBI, I think the role of leadership was to define what True North is, which is turning discovery into cardiovascular health, and then to define how we were going to go about doing that, which is in part supporting investigator-initiated peer-reviewed discovery science, and in part listening to the community about where we need to lean in. And in part training the next generation of cardiovascular scientists. So those are really the focus areas at the high level before we talk about what are the focus areas for scientific support, like addressing social determinants of health. And that leadership was really important because it drove the process of identifying those topics. And I had a life before NHLBI, and I used to be in Denver with the Colorado School of Public Health, and I was a volunteer with the Heart Association. Among other things I was doing professionally, I felt like I worked for the Heart Association, although they didn't pay my salary. University of Colorado paid my salary to work for the Heart Association. And we were trying to figure out, what were the information needs of school superintendents? Because one of the things we're really focused on is like, okay, so you can understand the information needs of the Department of Defense. It's about readiness and being able to have the funds to fly sorties and steamships and go to the firing range. And you understand the needs of business leaders. They want to drive down the curve, bend the curve down on healthcare costs for their employees and be able to get better worker productivity and so forth. Well, what are the drivers for school superintendents? So we got together a group of superintendents called a superintendent roundtable. I say we, it was Heart Association. I helped with that to some extent in Denver. And we heard from them, and their issues were, well, they're all held accountable for test scores. And so what's this focus that we care about, school lunch and physical activity and recess? I mean, the kids need to be their butts in a seat getting taught so they can do better on test scores. So the information we needed to generate was what's the evidence that better nutrition and physical activity improves students' readiness to learn. And there's actually pretty good evidence base behind that. And when you provide that evidence, you influence leadership, and when you get leadership buy-in, you can create change. And that's, you have to get that leadership buy-in and parental buy-in to influence leadership. So just a story of how that worked at the Heart Association. You're welcome, Jill. You're welcome.
Yeah, the word evidence or evidence-based has come up several times, and I know I'm preaching to the choir in this room, but there often are opportunities that present themselves where a group that isn't so steeped in the evidence and the science really wants to do something good. And they have an idea that sounds good, but there is no evidence. And so I think that's so key to make sure to bring that front and forward and really help, whether you're talking to a group of generals or school superintendents. I do believe in the basic good of people. Most of us want to do something good and have a positive impact. So making sure that since there's not enough of us already doing this work, that what we do is steeped in science and evidence is just so critical. So sorry for that little spiel, but Janet, you look like you're wanting to say something.
I do, and it actually, Betsy, what you just said provides a window for me. completely agree with the comments that Steve and David have made so far about leadership. But back to your point about we have to do something different, otherwise we're going to keep getting the results we're going to get. I have certainly lived that in a million hearts. We're not moving the needle, and for everybody to work so hard and not see the impact, it's time to do things differently. So I very much like the idea of, in the example of blood pressure control, creating a social norm around blood pressure control. We don't let our family members bounce around on car seats. We make them buckle up. In fact, the alarm will go off if we're not buckled up. I want the alarms to start going off around blood pressure control. I literally was last night thinking, if I could just put a flashing light on everybody whose blood pressure is under control so we could see each other. And we'd say, oh, your blood pressure's not under control. Here, let me help you. Or let me, somehow, I want the barbers to be the leaders. I want and it's happening in faith-based places all around the country where people are losing the person who sits next to them in a pew. And so they are very activated to do something, but to Betsy's point, they might not be doing what has a strong evidence base. So they might be investing in something that won't have the return that they're after. So how do we equip everyone at a community level to help each other get blood pressure under control? I don't want the car to start unless you can prove that your blood pressure is under control. You can't get on the metro unless you get my point.
So Janet is clearly not going to be elected for any political office in the near future. I appreciate it. I was thinking I'm fairly new in my role, and my new secretary recently went home to South Carolina and took an armful of data with her to try and get everybody in her family to pay attention to their diet and their heart health, which was great. I'm not sure she was successful, but still, she went with data. Did you have a comment or question?
Sure. I wanted to jump in right there with Janet's point because I think it came up at this great meeting last year. The key to success, it seems, for the seatbelts often are the kids in the back seat saying, "Hey, Mom, how come you didn't buckle up?" And I think to the point that Dr. Sidney made and to the great work that the National Institutes and NHLBI did in terms of primordial prevention and finding kids early with these potential risk factors, and then getting the norm in their head about what their risk factor levels should be going forward, their cholesterol levels, their blood pressure levels, and the influence they can have on their parents, I think.
Oh, okay, sorry. So I think, for us with familial hypercholesterolemia, it's a genetic condition, but we learned from the NHLBI recommendations for cholesterol screening in children came in part from an amazing effort at the community level in West Virginia over the course of 18 years, screening all these risk factors in fifth graders and learning from that we really need to, that we'd be missing kids if we didn't screen them young. And so implementing, I love, touching on implementing the recommendations of NHLBI to identify these risk factors early in life, creating norms among the kids to try to instill this primordial prevention, because addressing your hypertension 20 years after you've been living with it, or addressing your high cholesterol if you were born with it and waiting till you're 39 years old, it's not good enough. We need to do better. And I think there are just amazing combinations of work we can do together to improve that.
Thank you. Other questions or comments? We have a couple back there.
How are you doing? So I'm going to address exactly what you talked about. So I am looking to do a blood pressure coalition in barbershops in Baton Rouge, Louisiana. So we talked about the Mississippi and how that's the heartland. And I'll tell you is that it is the most difficult thing to bring the researcher, the medical profession, and the community all to understand the same thing. Unless you are a doctor or a researcher in our community, numbers don't mean anything to you. You could have a master's degree, doctorate, it does not matter. Numbers don't speak anything to that community. Then you have these researchers who don't understand the urgency of a community. And so I'm in the middle trying to get this nonprofit that cares about African-American males to understand that we can't just go into a barbershop and start taking blood pressure. And I have the Heart Association telling me, whoa, 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 we need to make sure we're doing the protocols and that we have these things. And then I have Pennington Biomedical Research Center who's saying, whoa, we need to like take 10 months, figure out the system, put the plan in place. And that's the challenge, right? There is the data and there is the thing, there's the process and best practices, but there is no, that I've seen, way to bridge that gap where you have community who wants the work to understand it at a level that is emotional and not just intellectual, to do the best practices with the data and manage all of that together. And I think that's the challenge, is if we can figure out a way to bring all of these different stakeholders together, that's how we can start addressing that.
You know, something Doug said reminds me of that comment, in that he was talking about the young soldier who didn't want to be told to stop smoking tobacco, but could maybe hear a message more around cutting down on tobacco. And I know for those of us who are clinicians in the room, you know, you don't get your patients to change behavior by telling them what to do. You find out what they care about and then plug it into that. I'm reminded of the San Diego Be There campaign, where they didn't go out to, and this is all around cardiovascular health, they didn't go out with the numbers. They went out publicly with very strong messaging and commercials, PSAs, et cetera, about people wanting to be there for their child's wedding, for their granddaughter or son's birth. You know, getting people, you have to meet them where they are. And I think you're so right that the data need to drive the activity, but the data aren't going to, they drive us in this room, but they don't drive most people out there in the world. But I appreciate that comment. Katie.
Yeah, so Katie Adamson with the Y. I was just going to step in and say that we have been trying to figure out how to integrate community with the health system. We're most known for the diabetes prevention work that we've done, but we more recently have been partnering with CDC's Heart Disease and Stroke Program and Million Hearts and the American Heart Association on a blood pressure self-monitoring program in communities. We're now in 28 states. We started with a stroke belt. We've seen a 43% reduction in those who joined uncontrolled who are now controlled, or 43% of those who joined uncontrolled are now controlled, a 12% reduction in systolic blood pressure, and a 7% drop in diastolic. A third of our participants are African American, so there was an intentional focus on the high-risk population. It's a heart health ambassador program where what we have found is not even just that people don't know their numbers, people get given a cuff and don't know how to use it. And so if we can just teach them how to use their cuff and have them track it and then know what their triggers are, we see a huge reduction in high blood pressure. And people are very comfortable coming into a YMCA as they would be with a barbershop in a way they don't want to tell their doctor they don't know how to use a blood pressure cuff. It's just too intimidating. So they say, yeah, I'm doing it. I'm doing it. But with somebody at the Y, a lay health leader, they're much more comfortable sharing that. And so just being able to give people the tools they need to get control has been very successful. What we need is payment. We need to be working, and we were just talking to the chronic disease directors earlier because CDC is funding them to look at how to get payment for this. But it's not enough to have these programs. And even if we have these programs and we get payment, as we did with the diabetes prevention program in Medicare, the systems have to look at us differently than a healthcare system. We are not a healthcare system. Don't treat us like one. We're mission focused. We're nonprofit. We're not out for fraud and abuse. We're out to reach as many people as possible. So when you reimburse us, think of us not like a health system. If you over bureaucratize the community, you might as well have not done it in the first place. So those are some learnings and thoughts, but however we can move other networks to be doing similar approaches, parish nurses and others, this model seems to be working.
I just want to call out the Y as an extremely valuable participant we have a home monitoring, blood pressure home monitoring leadership council, and the Y is represented on that council to try to help us work through the myriad obstacles in making home monitoring a widespread and sustainable practice. Thank you, Katie. American Heart Association and others are also helping.
I know we have a couple more at this table.
General, my dad retired as a colonel in the Air Force. I think it's the best department of Wright. When I was 11, I thought there were two kinds of people in the world, civilians and military. That was me. I speak around the country. I get up and tell them about my stroke, about how it changed my life, how now I exercise almost every day, how I changed my diet, how I changed everything. I heard a bit about this, but is there a way to tell the audience in regular speak this room, and I admire all of you. This room is full of technical speak. How do I tell them what you told me?
Does anybody else want to take that on? I do think there are ways, and I think that getting back to what I was saying about the Be There campaign in San Diego, it's about meeting people in ways that they'll understand. So if you want to talk about physical activity, I'm not sure saying what the latest, recommendation of how many minutes of vigorous activity or moderate activity, et cetera, is going to get there. But talking to them again about living a longer, healthier life so they can be there for the events they care about. And how do you do that? And how do you start taking one step at a time? There are a number of different groups in addition to the Y that have great success in some ways at getting people to change their behaviors. I think about Weight Watchers, for example, and getting many people, maybe they don't meet their ultimate targets, with a high degree of accuracy, but they do get people moving and doing more activity. So I think there are a number of ways to do that, probably beyond what we can address right now, because I want to get to one more question and then have a little time for wrap up, but we're all happy to talk to you more, I'm sure, Mark.
Hi, Stan Shandling. So here's a couple of things to keep in mind. When we talk about seatbelts and child restraints, that norm took about 35 years, okay?
Yeah, it didn't happen overnight.
And it, right. Nor did people who were in accidents, that lost their lives or were injured. So here's the thing to keep in mind. As far as seatbelts were concerned, one of the things that led to differences were laws, actual laws. And also there was funding differences state by state, where the National Highway Traffic Administration gave states money if indeed they enacted laws, okay, and withheld money if they didn't. So there are those types of incentives that we can look at. Now, with regards to what we're talking about here, and one of the things that I've noted year in and year out is this idea. Human behavior is not on a continual improvement mode. I've said this over and over and over again. And we think that we should be here. And rightfully so, I get it. But human behavior is not that way. We even individually, we look at things where, yes, we get better, whatever that may be, and then guess what? We kind of stabilize for a while. What we try to do here is try to find intervention points to assure that it doesn't get worse. Okay? Those are those shots of adrenaline that we need to do in the work that we do in order to keep that curve going better, in a better direction. But we have to keep in mind that there are just certain things that, hey, are we okay to be in a stabilized mode for a while? Okay? We don't want to get worse, but are we okay being stable for a while so that the populace gets used to these ideas?
Mike, did you have a quick, I saw your hand go up. Okay, I think we have time for that, and then I'll wrap up, and we'll be on time.
Okay.
Yeah, just to pick up on what Stan said, smoking and child safety, we had policy levers that we don't have necessarily for hypertension, but to pick up on what Janet said, and some of the lessons from the 83 champions, typically health has been a responsibility that has been sort of foisted upon the health professions, in some cases given to the health plans. And I think historically it hasn't been sort of looked at as a collective responsibility. And I think raising the level of awareness and raising this to a national priority and making it a collective responsibility, so every touch point in people's lives, whether it's at work, whether it's in church groups and community groups, everybody has a role to play and can play a role. But until we get it to that national level of priority and a collective responsibility, there's always going to be that sense of that's somebody else's job. So I think that there's a lot to be learned from what's going on in the Million Hearts campaign and how we can disseminate that sense of priority and collective responsibility broadly across communities.
Thank you, and thanks to all of you for the work that you do every day. I'm relatively new to this crowd. It's the 16th annual meeting, and yet it's only my first annual meeting. However, I did want to tell you just a little bit of what I'm committed to do at CDC as the director of the Division for Heart Disease and Stroke Prevention. We are going through a strategic planning process, a rather rigorous one, because we've done a lot of good work, but as Janet noted, the needle has not been moving, at least not with the speed that we need it to move. And so we need to figure out how to do some things differently. And I think this gets a little bit to your point, Mike, the collective action. You know, we fund a lot of state and some local health departments and territories. They do great work. We fund a number of people in this room. You do great work, and yet we haven't. With hypertension control alone, we haven't moved the needle. We are going to double down. We're pulling, all the stops to do what we can around hypertension control as our top priority for now. Not our only priority, but to see if we can't start to make that not just budge, but really move, because none of us are patient. We want to see it at 70%, 80%, 90% nationally, not just at the Kaisers of the world. So one strategy we're going to take that's a little bit new, we've done some of it, but is much more engagement with the private sector, with businesses, with pharmacies and others that should know that they have skin in the game. I think these sobering data about the 35 to 64-year-olds, while rather tragic for those of us who've been trying to prevent this all along, actually may be a real springboard to get more people engaged so that we can ignite others to help us with this work and have more collective action. So we will double down on hypertension. We will continue to focus hopefully with a little more laser point focus on priority populations such as African Americans and the 35 to 64-year-olds, and strive for much broader engagement and ignition of others. So that's our plan at CDC for now, and we really appreciate having all of you as partners and folks out there doing the hard work. Thank you, and thanks to our panelists. I think we're ending on time and ready to go.
Thank you. So I just, and I've got mugs for y'all, so don't run this way so I can hand you your mugs. But before you run off, but I just, I think the National Forum has a role.
Are the mugs less than $25?
That's right.
Are they less than $25?
They are. Okay. $2. I don't want to impair your ethics, so I'll let you take them. But I want to say, I think one role that I see a critical role of the National Forum is to really, and we've already started building out an infrastructure as one of our goals, is to how do we have a clearinghouse amongst everybody's got success stories and has unique insights, and how do we disseminate that information? I mean, Million Hearts is a platform, CDC, all of you individually, and so I think I'd like to see, I'm the outgoing chair, but the forthcoming group is really how can we do better to disseminate not just evidence-based stuff, but things that you all anecdotally have had work for you. How do we message better, sample scripts for how do we communicate in not to our NPR audience, but to maybe the Fox News audience that's in terms that resonate, because we're missing huge opportunities here. So moving forward, we'll kind of keep you all up to date on that. Thank you very much.